Hi, my name is Claranne.mathiesen. I'm the Director of Medical Operations at Lehigh Valley Hospital's Neuroscience Service Line. I'm here today with Erin Conahan, who's our clinical nurse specialist with the stroke program. This is the third lecture in a series of 3 as part of our 2006 annual stroke update. This particular 2016 annual update. This particular topic, we will be talking about large vessel occlusion and the advances in endovascular reperfusion. So Lehigh Valley Hospital Cedar Crest has been a comprehensive stroke center since 2012. We have a long-standing history of doing endovascular procedures for patients suffering stroke, and are very proud to share with you a little bit about why this helps our stroke patients have such good outcomes. So in ischemic stroke, the mechanism of injury comes from the interruption of blood supply to the brain. So what happens is you have a blockage, either with a clot or with plaque that has over the years narrowed that blood vessel so that blood flow cannot get through. You have a limited amount of time to turn this around before you have irreversible brain tissue damaging. So one of the immediate goals of reperfusion therapy is to get the blood restarted to that injured brain. So on average, per 1 second, 32,000 brain cells die. What reperfusion allows us to do is to treat the stroke and hopefully have a smaller scar or brain tissue that has become permanently damaged. So in treating these patients, the concept of penumbra, or tissue that is viable but at risk, is very important to understand. This is the tissue that surrounds the immediate area of tissue that has already been injured irreversibly by the actual blockage of blood flow. So when your patient has symptoms, they're going to have symptoms related both to that tissue that has already died, but also to that tissue that is starved for blood and oxygen. So one of the things that we do know is that we have a limited period of time that we can intervene to rescue that rim of mild to moderate ischemic tissue that lies between the normal brain and the infarcted tissue. So if you think of it sort of like the donut, with the hole being the tissue that's already dead and the whole outer ring being the mainstay of the donut, we want to get to that area as quickly as possible. So some of the things that we have grown and advanced in is looking at imaging to guide decision-making and to help drive treatment options for patients. So early on, we are able to get advanced imaging to help dictate how much brain is already gone and how much brain is still underperfused that we can offer an intervention. So as you can see here, you can see a CAT scan. You can also see an MRI scan that gives us the ability to look at symmetry and to pick up where there is tissue that has already changed, as in the case of an infarcted brain tissue, and then allow us to sort of see what the blood flow is. And you can see these areas of underperfused brain that we may be able to offer some intervention with. We're also able to layer on that some imaging that gives us advanced vessel information that would allow us to be able to more precisely locate where that blocked blood vessel is. So if you think of this as a problem within your plumbing, you want to think of these as your major pipes. So your carotid artery gives way to your internal carotid artery, gives way to your middle cerebral and your anterior cerebral artery. And in the posterior circulation, you have your vertebral basilar arteries and your basilar arteries that supply the posterior portion of your brain. So Dr. Schaff likes to use the analogy that if you think of these as your major roadways, if you have to get a supply of blood to an area by an alternative route, meaning other blood vessels taking over and doing more work, it's going to take a lot longer to get to where you want to go for your final destination. So if we look at some of the data that's available that helps define large vessel stroke, about 40% of all ischemic strokes are large vessel in origin. And these strokes typically come because they are the largest blood vessels that are most commonly affected as we age and as we have vascular risk. If these are left untreated, patient prognosis with these types of stroke can be very poor. And especially for our younger patients who have less room to have swelling, which often accompanies large hemispheric stroke, so their survival rates are mortality rates rather are even higher. So if you look at a blocked carotid artery, it tells you that there's about a little bit over 50% mortality rate for that patient suffering that untreated. The same thing with the middle cerebral artery, and that percent goes up, as I mentioned, the younger that you are. So our call to action is so much greater in these territories so that we can turn that situation around for that patient. As mentioned in one of our earlier lectures, IV-TPA, although approved and available since 1996, is not really a very good drug for reversing stroke symptoms in ischemic strokes. The efficacy of this medication diminishes from time of stroke symptom onset. So to get the biggest bang for the use of IV-TPA, if you give it within minutes of the start of the stroke, you're likely to get a more complete revascularization for that patient. The further you get out past the 2-hour mark of starting this drug, the less likely the effectiveness of this medication is going to be. And this slide here shows in the individual vascular territories what the effect of that medication has been. This is useful information, so when you hear people talking about where they think that blockage is, it's so important then to ask that next question, is this patient going to have a mechanical reperfusion? Is this patient a candidate to go on to have an additional treatment? Because as you transport this patient, it's going to help guide the speed at which you want to kind of ramp up movement of that patient. Anterior circulation stroke signs. So we are able to go after anterior circulation stroke from 6 hours from the start of symptoms. So in looking at these, this will show you what the clinical presentation of each of these vascular territories presents. And this is what you can expect to see when you do your on-site clinical exam or when you get information related to that patient from the referring facility. So typically, if you look at a middle cerebral artery stroke or an ICA stroke, you're going to have involvement on one whole side of that patient's body. When you look at the ACA territory, you're typically not going to have arm involvement. You're going to have more likely leg involvement and then some other isolated symptoms. Posterior circulation is a little bit more tricky and oftentimes can be missed, especially when you look at the symptomology that posterior circulation strokes typically present with. This has been described in the literature as the 5 Ds, but I can tell you this is sometimes very difficult to tease out, and oftentimes we've had patients present almost looking like they have flu or kind of malaise of a different origin, only to find out that this started suddenly and we should have been thinking stroke from the get-go. Posterior circulation strokes, they're also able to intervene a little bit further out. As we mentioned earlier, the mortality is so much higher in these patients. They typically will attempt reperfusion out as long as 24 hours from start of symptoms, again, because the mortality is just so high that most patients would say, give me any chance, and go ahead and try to turn this around. As we mentioned earlier in our series of lectures, pre-hospital stroke scales has been an area of increased attention. As we've looked at the value that mechanical reperfusion brings to our patients, it's important to determine, is there an easy way that we can recognize this in the field and more quickly refer patients to the centers that can offer this type of intervention. So presently there's a number of scales that are being tested. We expect somewhere soon that the American Heart will be making more formal recommendations with regards over the sensitivity of which pre-hospital stroke scale might be the best to go out there and teach our EMS colleagues and adopt in the pre-hospital arena. Many of these are based off of components of the National Institute of Health stroke scale. The NIH stroke scale is an 11-item scale that is somewhat felt to be kind of clunky to use in the pre-hospital setting. These 4 scales, Cincinnati Pre-Hospital probably being the most popularly used one. The Los Angeles Motor Scale, LAMS, is also utilized by very many. MEND, which is a component of the acute stroke life support course, and then RACE, which has been another scale that's being piloted in the EMS community, again, in a hopes of identifying large vessel occlusion and helping to make triage recommendations in the field for this time-sensitive emergency. So why this is so difficult in the field? One of the concerns is that not all hospitals have endovascular capabilities. Some hospitals have endovascular capabilities but don't have 24/7 resources, and this can be particularly difficult if you're referring patients and you don't know what resources are available. Patients that go to a primary stroke center that do not have endovascular capabilities and need to go to a comprehensive stroke center then require oftentimes critical care transport, which may not be readily available to move those patients. We feel very blessed to have the efforts of our MedEvac crew and our critical care transport crew that is available to help move patients within our region and again provide that expertise in nursing assessment that is maintained throughout that transport. Endovascular treatment has really revolutionized acute stroke management in allowing us to get up there almost like what PTCA has done for acute MI. Here at Lehigh Valley Cedar Crest, we do upwards of 80 cases per year of this type of treatment, and our doctors have gotten increasingly adept at opening up these blood vessels. Our current median door-to reperfusion time is 71 minutes, which is well under the national norm of 111 minutes. And we're very proud of that. To let you know, when you call and say you're bringing us a patient, these docs put everything on hold and are actually waiting for you to come. So when you're moving these patients either by air or by ground with lights and sirens, we really appreciate how quickly you get those patients and how well cared for they are in the course of their journey. Again, this slide, which you've seen before, highlights the state of Pennsylvania and the current status of hospitals that have been externally validated as primary stroke centers and comprehensive stroke centers. It does call to mind that if you're in the middle of the state, you may have a little bit more difficult time getting acute stroke management and may require a more carefully coordinated transport plan. As we mentioned previously in our series of talks, telestroke has been around since 2009. It has been a way that we have been able to increase access to neurological expertise, and it involves the sharing of both radiographic imaging and the ability to perform a joint clinical exam. It certainly has allowed sites that do not have neurologists to still treat stroke patients, and has allowed us to interact with patients and families that are in the middle of having a time-sensitive neurologic emergency. I'm going to turn it over to Erin, who's going to talk a little bit more specifically about what happens when a patient is referred for neuroendovascular treatment.
Okay. If you had to describe what goes on in the endovascular suite to a patient or their family, a good way to do that would be to say that it's the cath lab for the brain. Many people in our community are familiar with cardiac catheterization procedures. So what the vascular neurologists and neurointerventionalists have been able to do is take that experience and success of the cath lab for coronary treatment and apply those same strategies to open up vessels within the brain. The rooms are very similarly set up, and in some facilities, these procedures actually do take place in their cardiac cath lab. The similar approaches are used, so they do go in through the groin to access the large vessels to take a pathway up to the brain. Many of the catheters are similar, the biggest difference being that the vessels in the brain are much smaller than our coronary vessels. But literature has shown us that we're following in the path of the cath lab. And just as for MI, you see more and more patients going to cath lab than getting drug, it's anticipated that we will see the same with stroke care. Endovascular treatment allows that expansion of the treatment window. The one hard and fast exclusion for endovascular treatment is having an occlusion in a place that they can reach. Once they know that there's a blockage in an artery in a place that's accessible, we can then start to see what kind of treatment would be best for that patient. As Claranne had mentioned earlier, our team has the ability to drip a lytic drug directly onto that clot in hopes of dissolving it. Because of the success of the newer catheters, we don't see this used too often, but it may be used as an adjunct to a mechanical device. Mechanical devices, if used without additional drug, can take us out to 8 hours of treatment time from that symptom of onset. So that gives our patients more opportunity and greater chances of being treated. Similar to the cath lab, our interventionalists may also do vessel angioplasty, stenting, or different methods to interrupt that clot and aspirate that catheter out. So with time and evolution of treatment, we're able to have more opportunities to treat those patients. The first catheter for endovascular treatment was approved by the FDA in 2004, and it's called the Mercy Clot Retriever. This corkscrew-like device was passed through the clot, ensnared the clot, and then pulled that clot out. That device allowed us, once the vessel was accessed, to get the clot out within about an hour. The Mercy Clot Retriever, because of advances in catheter technology, is not used very often. The next device that was FDA approved is the penumbra aspiration device. So you can think of this similar to a shop vac for the brain. The interventionalist takes the catheter up through the clot, is able to mechanically disrupt it while turning on an aspiration catheter and then sucking out the clot and the pieces. Again, this advance in technology allowed us to decrease that time to treatment to about 30 minutes. Our newest technology, and what many of the recent trials have looked at, are devices called stent retrievers. They were approved for treatment in 2012. And what these stent retrievers do is once that catheter is up next to the clot, the stent is expanded and it pushes the clot away to the walls of the vessel. Once that clot is pushed away, it allows a tunnel of blood to reperfuse that area that wasn't previously getting enough blood. The catheter is left in place for about 5 to 10 minutes, typically closer to 5 minutes, and then it is very slowly withdrawn, and it's not unusual to have it withdrawn using one of the aspiration catheters. Our team is now able to open up blood vessels in about 5 minutes from getting access to that clot. So again, when we're talking about time is brain and getting treatment started closer to when that symptom started, 5 minutes versus 30 minutes or even an hour is huge in that patient's brain. So just to bring it all to a close, we're going to look at a case scenario. So this is a 44-year-old male who woke up the day prior to arrival, and he had a headache. He then developed some left-hand clumsiness. He went to work, and his symptoms got worse. So this is his CAT scan when he first arrived to Lehigh Valley Hospital. And as this red circle nicely highlights, there is a density sitting in that vessel. That white density in that vessel represents clot. So what we're able to do is his CAT scan didn't show many ischemic changes. So what our team did was took him to the MRI suite. And on MRI, we were able to see right here this infarct that matches where that clot was on the CAT scan. Then gave him dye to light up his blood vessels, and we were able to see right here this cutoff of his right middle cerebral artery. So this is the left side. You can see those normal vessels. And on the right side, we do not see those vessels. So clearly, that's where the cutoff is. What the radiologist does is then looks at the size of the infarct versus the territory at risk. So I'm hoping that this image shows you that while his infarct is only about half of the right cerebral hemisphere, his whole cerebral hemisphere is at risk, tissue that can be saved. Now what this didn't show us, and what you can see up here in the first angio pass, is this circular outpouching here. This patient actually ended up dissecting his carotid artery. So when he had that initial symptom of right-sided headache, that was probably when the dissection occurred. What happens in dissection is that there's a tearing in that vessel that clots can adhere to. When his symptoms got worse the following day, the hypothesis is one of these clots had traveled up to the brain and had blocked that cerebral artery. So what they did initially was they wanted to make sure they had this highway to the brain opened up. So they were able to place a carotid stent, and they helped to keep that vessel open. And they also eliminated that extra pouch of the dissected artery. Next, they could go ahead and pay attention to that blocked vessel. So again, as you can see, you have blood flow coming out here to the anterior cerebral artery. And then here you can see where there's no contrast enhancement after that occlusion. After using aspiration catheters and stent retrievers, you can see that there's now blood flow reestablished to that cerebral hemisphere. So some takeaway points when dealing with that large vessel occlusion patient is that stroke is a heterogeneous disease. No two stroke patients are alike. So one patient may have a middle cerebral artery stroke, and it may present differently than the next 5 patients that come in through the door. Speed and efficiency are paramount. This is in all facets of care of the stroke patient. So in recognition of that stroke symptom, getting the patient to the appropriate center, an effective stroke workup, and decision to treat. The sooner treatment is started from the symptom onset, the better chances of these patients having good outcomes. Modern mechanical devices work, and they work quickly. So within the past year, 5 trials have shown that the newer catheter technology opens blood vessels faster and safer for these patients, leading to better stroke outcomes. And again, some data is suggesting that imaging to revascularization less than 1 hour from that symptom onset, you can arrest even that ischemic core, that initial tissue that dies in that stroke. Thank you for your attention, and thank you for your ongoing care of our stroke patients. If you have any questions, please feel free to email us. Thank you.